appreciate the invitation to be here with all of you at the Bay Area Cancer Connection. And I know that it is, this is in collaboration with today's event with San Francisco Fire, San Francisco PD, the Department of Emergency Management, sheriffs, and our very own United Fire Service Women, which is an employee group of women in the San Francisco Fire Department. So I'll just give you a little bit about my profession, just a little snapshot, because otherwise I could be here all day. But firefighters have a higher likelihood of developing cancer than the general population. But we've also been really proactive and forward-thinking, thanks to people like Heather Buren, who's on this call. You know, years ago, you probably know, we took part in the Women's Firefighter Biomonitoring Collaborative, and which was a great group of women scientists, firefighters, researchers, all sorts of great people. And, you know, we've seen some results from that particular study. But we also, what we did, we also went around the country and we started teaching, which was before any other fire departments started teaching about cancer prevention and awareness. And so now there's a groundswell within the fire service about it that, you know, we didn't have 8 years ago. And my own personal story is, you know, in 2012, I was diagnosed with triple negative breast cancer, and within 2 weeks of my diagnosis, I'd had a double mastectomy and a port implanted in my chest. And I then had 16 rounds of chemo, which, you know, was kind of a drag, but, you know, I am fortunate enough that I work in San Francisco for the San Francisco Fire Department, so cancer is presumptive for firefighters now if you have a certain number of years in the profession. And I'm also, you know, I also know I'm one of the lucky ones because, frankly, I'm still here and still kicking. But, you know, during, like, what I really want to say is during, like, super challenging times like we have right now in the world, which seems a little chaotic, I like to remember, you know, things that I'm grateful for. And, you know, I want to remember that there are so many good people working on this issue and other issues, but today specifically the cancer issue, there are so many good people working on you know, on stuff, and you come together to work on whether it's education or studies or fundraising or care or whatever. And you know, that gives me faith in people, and it's people like you. So thank you, each one of you, for all the work that you do. And you know, everyone is valuable, from whomever is vacuuming the floors to the, you know, the head honcho. Everybody's important, and I'm grateful for that and for all of you. So I understand there are a lot of smart people here today, so I'm going to cede my time in a minute, but one of these smart people that I just met today is Erika Bell, and she has a P, an H, and a D after her name, which means she's really smart. And she's the manager of information and education at the Bay Area Cancer Connection. I'm not even going to read off like her degrees because I don't think I could pronounce them all. She's that smart. So I just want to introduce her, hand it off to her, and thank you for this opportunity, and thank you for the work. Sister Erika, you're up.
All right, thank you so much. I'm just gonna start sharing my screen here. Okay, thank you so much for joining me today, and thank you for inviting me to speak to you all. It's my pleasure to be here to speak to you about some breast cancer basics. And as Chief Nicholson said, I'm the manager of education and information at Bay Area Cancer Connections, where I've been for about 10 years. Prior to that, I earned my PhD in San Francisco at the University of California, San Francisco. And then I also did a short postdoc at the university. Oh boy. There we go. Okay. So let's start by talking about what is cancer. And this might be very basic to some of you, but as a molecular and cellular biologist, I like to think about things in terms of the cellular level. And at that level, cancer is a group of diseases where the cells in the body grow, change, and multiply out of control. So what you're looking at in this slide on the top is what normal cell division looks like. I don't know if you remember back to high school when you learned about mitosis or cell division, but normal cells incorporate signals from their environment and they get a green light go or a stoplight red in terms of whether the conditions are correct for them to grow and then divide into two cells. So they incorporate a lot of information about the conditions in their environment and divide accordingly. If they get damage from their environment, then they have built-in mechanisms that actually tell them to die. And there are two forms of cell death. One is a programmed suicide, and the other is more of a regular, death by circumstance. If you look at the bottom of the slide, this is how cancer cells divide. They no longer care about incorporating those signals from the environment. They pretty much have lost the red light, the stoplight, and they're always on go, go, go. In order to get to this state, they have to have accumulated multiple mutations in their DNA or their coding genetic material. So after having multiple mutations, these cells just grow whenever they feel like it, and this is what usually forms a tumor. So today we're going to focus on breast cancer, which of course is cancer that originates in the female breast tissue. And breast cancer, besides non-melanoma skin cancer, is the most common type of cancer in women in the United States. So the data you're looking at here is from 2018, where about 266,000 women in our country were newly diagnosed with breast cancer. This accounts for about 30% of all new cancer diagnoses. If you then look at the estimated number of deaths from breast cancer, it's second to lung cancer, but represents about almost 41,000 women that died in our country from breast cancer. So it's a major public health condition, and it's extremely common. Another way of stating this data is to say, and you've probably all heard this before, that 1 in 8 women is diagnosed with breast cancer in her lifetime. If you look at an individual who's at average risk for developing breast cancer, this amounts to about a 12.5% chance that an average risk woman would be diagnosed with breast cancer in her lifetime. So when I speak about breast cancer risk factors, I like to divide them up into 2 groups. One group that represents unmodifiable risk factors, things that either we're born with or we can't control, and then risk factors that are actually under our control, our behaviors that we can modify to reduce our risk. So first, let's delve into the unmodifiable breast cancer risk factors. I think the first one listed here is quite obvious, that gender, being female, is a big risk factor of developing breast cancer. But many people don't actually realize that men can also develop breast cancer, and about 1% of all breast cancer diagnoses are in males. Age is also a risk factor. As we age, the risk of developing breast cancer increases. The risk for a 40-year-old is quite different than the risk for a 60-year-old, for example. Personal and family history also plays a role in risk. If you have a history of breast cancer yourself, you are at a slightly elevated risk for developing another new primary breast cancer. And if you have relatives in your family, the closer the relatives are to you, so if you have first-degree relatives, that have had breast cancer, your risk is higher than someone who maybe has second or third degree relatives. And your family history is important to share with your doctor so that they can assess your personal risk for breast cancer and recommend appropriate screening techniques based on that risk. You may recognize that breast density can play a role in breast cancer risk. And by density, what I mean is the ratio of fat in our breast to the ratio of functional tissue, which I will show later is called lobules and ducts. So the more functional tissue you have compared to the fat, the higher your breast density. And higher breast density is not only associated with difficulty in finding breast cancer through screening techniques, but is also in and of itself associated with an increased risk of developing breast cancer. So now when you go for a screening mammogram, you are required by law in several states to receive notification if you have dense breast tissue. And it's then up to you to discuss these findings with your doctor to determine whether you would benefit from supplemental screening. Radiation exposure can also increase breast cancer risk. So radiation exposure can come from many things. It can come from, diagnostic medical tests. If for some reason you had to have repeated X-rays or CT scans throughout your life, that could slightly elevate your risk. If you were diagnosed with a cancer as a child, something like non-Hodgkin's lymphoma, and were treated with chest radiation, that could increase risk of breast cancer. And then radiation exposure from natural disasters, for example, from our environment, can also increase the risk of breast cancer. Moving on in this list, if you start menstruating early, prior to the age of 12, which these days is fairly common, or you start menopause late after the age of 55, then you have an elevated risk of developing breast cancer. And this is largely because most breast cancers depend on the female hormone estrogen in order to grow. And so when a woman starts, or when a younger female starts menstruating, her estrogen levels are increased, her ovaries start working. And then if you enter menopause late, then your window of your body's exposure to estrogen can be long. And so that's almost like providing excess food, you can almost think of it as, for these potential breast cancer cells to feed on. And then a genetic predisposition, so an inherited predisposition to develop breast cancer, can very much increase your risk. And we often hear about two infamous breast cancer susceptibility genes called the BRCA genes. BRCA1 and BRCA2 are normally function in our cells to suppress tumors. All of us have these BRCA genes, and they're there so that when there's damage to our DNA, the body recognizes it, and these BRCA proteins, which are made from the genes, can repair that damage. But some people inherit a deficiency in these genes so that they're not working appropriately. And when that happens, the damaged DNA is not fixed appropriately. So these people can accumulate excess DNA damage within their cells, and this can lead to cancer. Hereditary breast cancer syndrome is sort of an umbrella syndrome that includes deficiencies in BRCA1 and BRCA2, but also can include deficiencies in other risk genes, things like BARD1, PALB2, CHEK2, or PTEN, among others. And changes or mutations in these genes can increase the risk of not only breast cancer, but also ovarian cancer, prostate cancer, pancreatic cancer, and skin cancers. And please pardon my phone in the background. I'm sorry about that. So mutations in these genes can increase the risk of breast cancer very significantly, on the order of between someone with mutations in these genes could have a risk from 60 to 80% of developing breast cancer over their lifetime. Only 5 to 10% of breast cancers are due to inherited gene mutations. So that means that 90 to 95% of breast cancers are not due to inherited gene mutations. And for many of these other situations, we don't actually know what caused the breast cancer. Although this is commonly one of the first questions I get asked by people that I meet with, what caused my cancer and how can I ensure that I won't get another one? Some people think that these BRCA mutations can only be inherited from their mother's side of the family. So if they don't have breast or ovarian cancer on the mother's side of the family, they might think that they're not at risk. But in fact, that's not the case at all. And these mutations can also be inherited down through the father's side of the family. So it's important to assess the incidence of cancer on both sides of the family. And if you see, say, a strong family history of prostate or pancreatic cancer, or even male breast cancer on the father's side, that may be indicative of an inherited gene mutation. Now, people with these gene mutations, because they are at significantly elevated risk of developing breast cancer, are often recommended different types of screening compared to people who are at average risk. So now let's move on to talking about modifiable risk factors. What things can you control to reduce your risk of breast cancer? And one thing we know is that alcohol consumption can play a role. So drinking more than one alcoholic beverage per day can significantly increase the risk of breast cancer, as can being overweight or obese if you are a postmenopausal woman. So surprisingly, for some reason, if you're overweight as a premenopausal woman, that actually decreases breast cancer risk, which I've never fully understood. But if you're overweight or obese into menopause, then that increases your risk of breast cancer. Again, this likely relates to the hormone estrogen, which is made in fat cells. So the more fat that you have on your body, the more estrogen you're making, and the more potential food for estrogen positive breast cancer. Probably coupled with obesity is physical inactivity. So if you do not exercise consistently, this can elevate your risk of breast cancer. And then use of hormone replacement therapy, the combined use of estrogen and progesterone to deal with the side effects of menopause, can significantly increase the risk of breast cancer. This was acknowledged many years ago now, and as a result, doctors stopped prescribing hormone replacement therapy as frequently, and we saw a drop in the incidence of breast cancer from that point on. Sometimes women going through menopause have significant side effects that they actually do still benefit from hormone replacement therapy. So it's not as if it's never prescribed anymore, but doctors are just much more cautious about it and much more cautious about the length of time that women are recommended to stay on the therapy as well. So I like this little chart from another local organization called Zero Breast Cancer. And they suggest 13 ways that you can reduce your personal risk of breast cancer. So we talked about many of these already, but let's just review them again. So Be physically active, and it doesn't take all that much. Something as simple as going for a walk for 30 minutes several days a week, so that you add up to about 150 minutes of active exercise throughout the week can reduce your risk. Also, eating a healthy, balanced diet with lots of fruits and vegetables and whole grains might reduce your risk of breast cancer. Drink from your own glass or stainless steel bottle and avoid bottled water. So this is recommended by Zero Breast Cancer because they think that the lining of plastic bottles may contain chemicals that can increase your risk of developing cancer. This has not been proven by any studies, but this organization is very keen on investigating the potential environmental causes of cancer. Not smoking is an important thing to do, not only in reducing your risk of lung cancer, but on other cancers as well. It's still a little controversial as to whether it can affect breast cancer or not. But certainly limiting alcoholic beverages to 1 or none a day can reduce your risk of breast cancer. And then this try to list is suggestions to limit the amount of potential toxic chemicals that you put on or into your body. So they suggest using very basic non-toxic household cleaning products. Also, if you use beauty or makeup, to pay attention to the chemicals that are in that. And there are some great resources by the Environmental Working Group, or EWG, which will allow you to go into a store and even just scan the barcode of certain products and see if they contain any of these dangerous chemicals. The EWG will give you a rating of the product as to whether they consider it safe or not. Zero Breast Cancer suggests cooking in stainless steel or cast iron and avoiding non-stick pots and pans, as they can contain coatings that have possible cancer-causing agents on them. And they also suggest avoiding dry cleaning, again, because of the chemicals that are involved in that process. One way to lower your risk of breast cancer that I did not mention is that if you have children, to have them earlier in life, and when you have them, to breastfeed them for as long as possible, and ideally for 1 year, as this can reduce the risk of developing breast cancer. Minimize exposure to radiation. So if you're having medical tests done, it's important to pay attention to things that involve radiation and things that don't, and limit the ones that involve radiation if you can. Obviously, if you need a diagnostic test, you need to do it in some cases. And then we talked about avoiding estrogen and progesterone hormone replacement therapy, and then knowing your family history of breast cancer and discussing it with your doctor. So I think there's a lot of confusing information about diet out there and what a cancer prevention diet might look like. So I just wanted to touch on this really quickly. This diagram is from an organization called the American Institute for Cancer Research, or AICR. And they really focus on what proper nutrition for cancer risk reduction should look like. So they've developed this new American plate, whereas the old American plate would be filled with meat and potatoes and maybe a little bit of vegetables. They have reimagined our plate such that 2/3 of the plate is covered with fruits and vegetables and whole grains. And then only 1/3 includes protein. If you choose that protein to be animal protein, usually dietitians suggest getting that from a good source, organic or pasture raised if you can. and limiting red and processed meat whenever possible. So I like to think about eating the rainbow, which you see the beautiful heart on the other side. If your plate looks like that on a daily basis, then chances are you're getting lots of phytonutrients, which can reverse the damage to our cells. It can help in antioxidants, can help in repairing damaged DNA and reverse the process of cancer development. So let's talk about the symptoms of breast cancer. And in many, many cases, there are no symptoms. So most women that I speak with were diagnosed from some type of screening mammogram and not from feeling or seeing anything different. But if there are symptoms, these are possible ones. So of course, finding a lump in your breast or in the underarm area can be indicative of breast cancer. Most lumps turn out not to be cancerous, but it's very important to get any lump in your breast or underarm checked out by your doctor. Not only a lump, but also breast cancer can form a thickening of the breast. And this is characteristic of a type of breast cancer that is called lobular breast cancer, where it doesn't form a nice little mass that you might feel and wiggle around, but it forms more of a thickening. So it's important to look for that as well. Sometimes breast cancer can cause redness or swelling in the breast, not quite as common. It can also cause a change in the size or the shape of the breast. So it's important to know your own breasts and look at them, touch them regularly, know what's normal to you. And if something is looking abnormal or feeling abnormal, to bring it to the attention of your doctor. Breast cancer can sometimes form a dimpling or puckering of the skin, or it might cause an inversion of the nipple, for example. It can also cause the nipple to secrete a discharge, which may or may not be bloody. Or it can, in some cases, cause pain in a particular area that doesn't seem to go away. So how is breast cancer detected? Well, I just touched upon being aware of what's normal for you, and that's referred to as breast self-awareness. Many years ago, it used to be recommended that women perform breast self-exams on a very regular monthly basis, and that is actually not recommended by all of the top organizations now, but breast self-awareness is certainly still recommended. A clinical breast exam where a doctor, maybe your primary care doctor or your gynecologist, goes over and touches every part of your breast to check for lumps, is also surprisingly controversial, as it hasn't been shown to increase the diagnosis of early stage breast cancer. So there are some organizations that don't recommend clinical breast exams, while others still do. Mammograms are an essential part of diagnosis, and these days most mammograms are digital. We now have a technology called 3D mammograms or tomosynthesis, whereas the normal digital mammogram just takes 2 views of the breast. A 3D mammogram or tomosynthesis is able to reconstruct an entire 3D image of the breast so that you can zoom in on particular areas of interest. And this new technology has been shown to decrease the rate of false positives and decrease the rate of callbacks because the radiologist is able to look more closely at a particular area. So there are some facilities in the Bay Area that offer tomosynthesis, and the American Society of Breast Surgeons actually favors this technique of 3D mammograms when possible. It does usually amount to a little bit more radiation than a standard mammogram, so it's important to note that. And then MRIs and ultrasounds are sometimes used as screening tools in women who are at higher risk, and they are ultrasounds especially are very frequently used if a woman is diagnosed with breast cancer, and MRI is sometimes used in that situation as well to get a better look at the site of cancer. So screening recommendations for women around the country, in this country, really vary, and they vary depending on the woman's own personal risk of breast cancer. As I mentioned, if someone is at higher risk, if they have a 20% risk or greater, then they are likely going to be recommended to have something more than just a mammogram. But recommendations also vary depending on the medical organization that you listen to. And so on this next slide, I don't want you to get overwhelmed by the amount of text there, but what I want you to take away from it is that there are several different recommendations from different medical organizations, and it's very important to discuss with your doctors which recommendations they follow and why, and then see if that fits with your personal thoughts about the issue. So for example, on the top, you can see that the American College of Radiology and the National Comprehensive Cancer Network, for example, suggest that women start screening with annual mammograms at the age of 40. So they would, when you turn 40, get a mammogram and have one yearly after that. This is in contrast to what the US government recommends. So the US Preventative Services Task Force says that between the ages of 40 to 49, it's up to the woman as to whether they would like to initiate screening or not, that there are potential benefits and potential harms, but they suggest that screening really should start at age 50, and that between the ages of 50 to 74, a mammogram is recommended every other year. They say that once a woman reaches the age of 75, there's currently not enough evidence to say whether she should continue with screening mammograms. The American Cancer Society has recommendations that sit somewhere in between these two, suggesting that between the ages of 40 to 44, women can have the choice to start screening mammograms, but that between the ages of 45 to 54, they should have annual mammograms. And then once they turn 55, if they choose, they can continue with annual mammograms, or they can switch to biannual mammograms, so every other year. And they suggest that screening should continue as long as the life expectancy of the woman is more than 10 years. One thing is clear, that screening and early detection that comes along with it saves lives. So what you're looking at here is a chart of the 5-year survival rates of breast cancer, depending on whether the breast cancer was diagnosed when it was still local. And what I mean by that is that it was limited just to the breast area. You can see that the 5-year survival rate in that situation is on the order of, 95, 96% or so. And then you can see that that survival rate goes down to just over 80% if the breast cancer has already spread regionally. And the first place that breast cancer usually spreads to, if it moves out of the breast, is to the area under the armpit, which contains several lymph nodes that the breast drains to. And then if the cancer has already spread somewhere else in the body, so a distant metastases at diagnosis, then the 5-year survival rate is quite low, on the order of 35% or so. So detecting breast cancer in its earliest stage when it's still localized to the breast is really the best case scenario in terms of survival. Next, I want to talk a little more about the biology of breast cancer. And what I want you to leave with is the idea that breast cancer is not a single disease. So you heard Chief Nicholson talk about her own breast cancer diagnosis as being triple negative, and you may not appreciate what that means. So I'm going to take you through the information that a woman gets about her breast cancer when she is diagnosed. So one of the first things that a pathologist, which is a doctor that looks at cells under the microscope in order to provide a diagnosis, looks for is what cell type did the breast cancer originate from? So in the diagram on my left, no, I think it's your left as well, you can see that the breast is composed of several different structures. Our breast has a lot of fat tissue in it, but that functional tissue that I talked about when I was talking about breast density is made up of lobules, which are cells that produce milk, and ducts, which are cells that carry the milk to the nipple. And breast cancer primarily originates in the ducts of the breast. About 70 to 80% of breast cancers originate in the ducts, and then the minority of them originate in the cells that line the lobules, so in those milk-making cells. So when a woman receives her diagnosis, she will know whether she has ductal carcinoma or lobular carcinoma. Treatment does not really vary based on this characteristic, but these two cancers can behave somewhat differently, with the lobular forming sometimes that thickening of the breast as opposed to a mass, and being a little more likely to appear in the opposite breast. And then if it spreads somewhere else in the body, sometimes it goes to different sites than ductal breast cancer does. If you look at the diagram on the right, what you're looking at here is taking a duct of the breast. So again, these are like the roads of the breast that carry the milk to the nipple. And if we slice that duct down the middle, you can see that normally the duct is lined by just a single layer of cells. And as changes or mutations develop in those cells, the cells start to grow when they're not supposed to. And they start to fill the duct. So about midway down the diagram, you can see what's labeled ductal carcinoma in situ. This is characterized as the very earliest stage of breast cancer, where you have abnormal cells piled up within the duct, but they have not yet figured out how to get out of the duct into the surrounding breast tissue. So this is called DCIS, or stage 0 breast cancer. If those DCIS cells gain more mutations and figure out how to break out of the duct and into the surrounding breast tissue, then it becomes invasive ductal breast cancer. Another thing that the pathologist looks at to classify breast cancer is 3 different tumor markers. And this allows us to categorize breast cancer in terms of different subtypes. So what's done here is the tissue that's taken out either from a biopsy or from surgery is stained for these 3 different proteins: the estrogen receptor, the progesterone receptor, and the HER2 receptor. And each of these proteins can either be present or absent on the breast cancer cells. And so a woman may be positive or negative for each of the 3 of these proteins. So when Dr. Nicholson said, Chief Nicholson said that she was triple negative, her cancer did not have estrogen receptor, did not have progesterone receptor, and did not have the HER2 receptor. Now, that represents the minority of breast cancers. Most breast cancers are estrogen receptor positive, and they depend on the hormone estrogen in order to grow. So you can see the hormone estrogen interacts with the estrogen receptor inside of cells, and this is a signal for those cells to grow and divide. Similarly, the hormone progesterone interacts with the progesterone receptor and signals to the cell to grow and divide. Now, with HER2 positive disease, we know that there's too much of the HER2 receptor on the breast cancer cells, but we're not entirely sure what growth factor activates the HER2 receptor. But whatever it is, when the growth factor and the HER2 receptor comes together, this serves as a signal for these cells to grow and divide. And that happens only in HER2 positive breast cancers. So again, you can be, the cancer can be positive or negative for each of these three proteins. And the treatment for breast cancer is largely tailored to these three factors, such that if it's estrogen receptor positive, one way of treating it is to block or take away estrogen in the body. And if it's HER2 positive, then one way of treating it is to block the HER2 receptor. And then I wanted to touch on staging for breast cancer. So I talked a little bit about in the previous slide that when the ductal cells are still all contained within the duct, that was stage 0 or very earliest stage breast cancer. Early stage invasive breast cancer is considered to be stage 1, 2, and sometimes stage 3 breast cancer. And the way that that staging is determined is by taking into account the size of the tumor in the breast, the subtype, which again means whether those three proteins, estrogen receptor, progesterone receptor, and HER2 receptor, are present or absent. And then the grade of the cancer cells, which is essentially asking, what do the cells look like under the microscope? Do they have a really strange shape? Are they growing particularly fast or slow? And what does their DNA or genetic material look like? And then stage also takes into account the number of lymph nodes that have cancer in them, and then whether or not the cancer has spread to distant sites. So outside of the breast, somewhere else in the body. And when all of these factors are taken into account, clinicians can determine whether the cancer is stage 0, 1, 2, 3, or 4. So essentially there's 5 different stages of breast cancer. I just wanted to touch on where breast cancer tends to spread to if it leaves the breast and armpit area. The 4 most common places that it goes to are the bones, the brain, the liver, and the lungs. And once it spreads to these areas, it doesn't suddenly become, say, brain cancer or liver cancer or lung cancer or bone cancer. It's still breast cancer because it originated there, but it is now termed metastatic breast cancer. And it's still largely treated based on those 3 proteins that are either present or absent. So what does treatment for breast cancer look like? Well, it involves local treatment, treating the breast and lymph node area, and then systemic treatment, or treating the rest of the body. So in terms of local treatment, this almost always involves surgery. So either removing just the cancer with a little bit of normal tissue around it, called a lumpectomy, or removing the entire breast, a surgery called a mastectomy. And then radiation is fairly common in breast cancer, especially if a woman has the smaller surgery, just the lumpectomy. Then radiation is often given to the entire breast area in order to prevent the chance of the cancer coming back there. In terms of systemic therapy or treating the entire body, we usually classify this into 3 different things. Hormone therapy is treatment that blocks estrogen in the body. And then chemotherapy is the more traditional systemic therapy that you often hear about. This kills all dividing cells regardless of whether it has estrogen, progesterone, or HER2. And then targeted therapy, which in breast cancer treatment often targets the HER2 receptor, although there are many other targets that can be druggable as well. And then breast reconstruction often plays a role in a woman's treatment. If she's had a mastectomy, then it's fairly common for a plastic surgeon to do some surgery to create a new breast where hers was removed. So all of these treatment decisions, the type of surgery, whether or not to give radiation, whether or not to give chemo, hormone therapy, or targeted therapy, depends largely on the subtype of the breast cancer, the stage of the breast cancer, and then the patient's overall health, and oftentimes the patient preference as well. So treatment is not just one straightforward thing. It often involves a lot of decision making on the part of the patient and interacting with the different members of her treatment team in order to assess the pros and cons of each type of treatment. So who are the members of the cancer treatment team? Well, you can see here there's quite a few of them. So women have to meet with all of these different medical professionals when they're diagnosed. You know, there's a surgeon whose role is to remove the cancer. And then there's a medical oncologist whose role is to prescribe that systemic therapy, whether it's chemotherapy or hormone therapy or targeted therapy. The radiation oncologist makes decisions about whether radiation is needed or not. The plastic surgeon plays a role in reconstructing the breast. And then a dietitian is the patient is often referred to support their nutritional health throughout treatment. A physical therapist often plays a role, especially if a mastectomy is done. And then sometimes an integrative oncologist or a naturopath is also part of the treatment team. And they can bring in integrative or complementary modalities that can reduce the side effects and increase the quality of life of the patient as they journey through the cancer experience. So this can often be overwhelming to meet with all of these different doctors and understand all of the information, not only about the diagnosis, but about the efficacy of different treatments that have been suggested for the diagnosis. So one of the unsung heroes of the cancer team is the support system. And that's really where Bay Area Cancer Connections can come into play. And so I want to spend the rest of the time talking about what we do at Bay Area Cancer Connections. So this is a little wheel of all of the programs and services that we provide. We have over 50 programs and services, all of which are provided at no cost to our clients. Our mission is to support anyone affected by breast or ovarian cancer with personalized services that inform and empower. So we offer programs that provide emotional support, information and educational support, and financial assistance as well. Our website is bayareacancer.org, and I encourage you to go on there and explore all of the programs and services that we provide. I'm going to delve in a little bit deeper into each component. So for emotional support, we have a number of different support groups. We, I think, currently have about 12 of them that are going on. And they're broken down in terms of whether the participants are newly diagnosed or in treatment, or if they're post-treatment, or if they have metastatic breast cancer. We also have support groups for people who are done with treatment and are in survivorship mode. We have a Spanish language support group. We have a hereditary cancer support group for people that have those inherited mutations that increase their risk of developing breast cancer. We also have a gynecologic cancer support group and a young women's group. In addition to the group format, which is great for many people, but some people prefer not to participate in a group, we offer 2 free counseling sessions with licensed therapists. This, again, is free of charge. We also have a buddy program, which pairs newly diagnosed clients up with someone who's already been through the process. So the buddy can talk to them about what their own personal experience was, what helped them in making decisions or helped them get through it. And this can be so comforting, just knowing that someone else has been through it and talking to them about what helped and knowing that they're on the other side. It's really an invaluable program that's all based on volunteers. And then we also have a helpline that's answered by staff and volunteers, many of whom have been through the breast cancer experience themselves. The helpline can provide emotional support and also help people navigate through our different programs and provide people with resources to other community organizations as well. We also have a lovely boutique that was custom built for us. It has a great selection of wigs, hats, scarves, bras, swimsuits, prostheses. Last fiscal year, we helped 152 clients in our boutique. And all of the items that are in our boutique have been donated to us, and we provide them to our clients free of charge. Importantly, this service of ours is not limited to just breast and ovarian cancer patients, but we also allow people with other cancer types to come in and visit and find something that suits them. The department that I'm in charge of is our personalized cancer information and education service. And you see me here with my coworker, Victoria, who also has a PhD in cancer biology. And we spend our time doing one-on-one consultations with people. We can do a variety of different things, but most of the time we're explaining their pathology reports or helping them understand test results that they've received, or talking through different decisions that they have to make. Maybe they're trying to decide whether or not to do chemotherapy or not. And we can help weigh the pros and cons of each thing, weighs the pros and cons of doing chemo versus not, for instance. We can also help people find clinical trials that they might be applicable for. We also have an annual conference and special presentations. So our annual conference is coming up on Friday, November 6th from 9:30 to 4:30. This will be our 17th annual conference, which we call Sharing Knowledge and Inspiring Hope. We traditionally hold it at Oracle, which is what you see in the photo, but this year, given the pandemic, it will be held in people's homes on the computer. It will all be virtual and it will be free. So if you're interested in learning more about breast cancer and its treatment, I encourage you to register. We also provide a variety of special presentations throughout the year, and these presentations are usually tailored to the needs of our clients. So some recent presentations that we've had have focused on nutrition, bone health, pain management, sleep and stress management, caregiving, We had one on healing sound meditation and beauty and wellness, etc. And Colleen, who you met earlier, is always finding great new speakers for us to fulfill those needs that our clients bring to us. So our recent presentation about pain management was in collaboration with Stanford and Cancer Care Point, Latinas Contra Cancer, and New Hope, a Chinese cancer organization. And I think we had over 100 participants, so really fabulous. We also provide financial assistance, and we recently acquired the Breast Cancer Emergency Fund, which now, because we support people with ovarian cancer, is termed the Breast and Ovarian Cancer Emergency Fund. Through this program, we support people who have been diagnosed with breast or ovarian cancer within the last 6 months, or who are in active treatment or have metastatic disease, with grants of a maximum of $1,000 to help pay for their living expenses, things like utilities, rent, food, transportation, medications, or co-pays, etc. In order to qualify, the person needs to have a household income that is either below or up to 200% of the poverty level, and must be a resident of San Francisco, San Mateo, or Santa Clara County. And then we also have a small fund called the Karen Swanson Fund that provides a grant for people living with metastatic breast or ovarian cancer, which will help fulfill an end-of-life wish for them, or help or get something for them that will improve their quality of life. We also have a variety of wellness and fitness programs. So our fitness programs include things like yoga and Pilates, and also a program called Healthy Steps. And our wellness programs include things like healing and guided imagery, mindfulness meditation. We have a writing program, and we offer Reiki healing sessions. We also have other things throughout the year that I haven't listed here. And then I'll end by just letting you know how we've coped with the COVID-19 pandemic. You know, like most people, we've had to change the way that we deliver our services, but that has not stopped our small but mighty team, which you can see pictured here. All of the staff are working from home for the most part, and many of our volunteers are volunteering from home. So you see our volunteer Judith over here, who's washing and caring for our wigs in her home. A few months into the pandemic, we're able to offer our boutique as an outside, sort of like a drive-by service. And this is actually functioning quite well. And we've been able to help quite a few clients in this safe way, which is wonderful. And then many of the rest of our programs are happening over Zoom. So our exercise programs are still continuing on Zoom, as are special presentations. And the vast majority of our support groups are happening on Zoom or over the phone. So with that, I'm going to stop talking and thank you all for your attention and for joining me today.